Ryan Stanton here with ACEP Frontline, Leadership and Advocacy Conference 2026. And we are now with this special episode. We're going to have two state leaders, physicians who've gone on to be within their state congressional representation. And Dr. Venkat here, Arvind Venkat, is a friend of mine from the board of directors here with ACEP, but also then took the step of running for state house in Pennsylvania. And we're going to dive into some of those things because we actually have a session here at Leadership and Advocacy, and I want folks out there to kind of understand not only the conversations we were going to have, but also kind of that take-home message of what it takes to be a physician leader and what it means. So first and foremost, welcome back. We don't get to see you near enough because you're so busy. But I guess if I showed up in Pennsylvania and you'd knock on my door eventually and I could interview you then.
Absolutely. Thanks for having me, Ryan. It's great to see you as a friend, as a leader in the college, as well as the host for this podcast. So thanks so much for having me.
Well, it's good to have you back, and give those that don't know out there your background in terms of practice and now what you're doing.
Sure. So I'm an emergency physician. I've practiced in Western Pennsylvania since 2007. I was at Allegheny General, which is the basis for the PIT, which I'm sure everybody on your broadcast knows about. I was an active member of ACEP. I was president of the Pennsylvania chapter, and then was fortunate enough to be elected to the board of directors. And then I decided to take the leap to, elected office outside of ACEP. So I ran to be the state representative for my area and was elected in 2022. And currently serve as the only physician in the Pennsylvania General Assembly.
All right, and that was actually going to be my next question, because I remember you talking about the fact that you're the only physician within the legislature. What does that mean? Mm-hmm. Because everybody knows, we were just down in the state leg and talking about monitoring over 2,000 bills. Mm-hmm. Every state has multiple healthcare bills every single year of all types. What's it like being the only physician representative within an entire state?
So it's a great privilege, and I'll start with an anecdote. When I was elected in 2022, I remember sitting in our state house, and a colleague of mine, I didn't even know his name, came over and said, "Hey, Doc," and I turned around, and he's like, "Can I talk with you about healthcare stuff?" And he started telling me about this very personal healthcare information about him and his family, and I was happy to talk with him, but I didn't even know his name. I was just elected. That kind of epitomizes what it means to be a physician legislator and unique, because healthcare is so personal to everyone. And you're right to say there's always healthcare bills in every state legislative session, obviously here at the federal Congress as well. And being the only physician legislator means that I'm always at the heart of the healthcare debates. And my colleagues on both sides of the aisle, I'm very privileged that they trust me to kind of give, candid perspectives about what it means to practice medicine and what it means for delivering healthcare in the legislature. The other part of it is that so many issues touch on healthcare, issues you don't necessarily think about as having a health aspect, but do. So whether it's housing or education or jobs or the environment, all of them have a health aspect. And so bringing the perspective of a practicing emergency physician informs those issues as well.
I was afraid you're going to do the old traditional, came up to you, "Hey, Doc," and then "I've got this rash." Yeah,
it was
the old traditional.
I was being, protecting his privacy, but you're not far off.
Okay, fair enough. All right. HIPAA safe zone.
Yeah.
All right, so us as physicians, when I go and do legislative stuff in Frankfurt, I often, leaving Frankfurt, we cross this very tall bridge over the Kentucky River, and I often just want to feel like driving off the side of it after I leave Frankfurt, because politics goes very much against our scientific mind. Our scientific mind is, here's the evidence, 1 + 1 = 2, follow the evidence kind of stuff. Politics is not about that. Talk about your transition an accommodation for the realities of politics while still having the mind of a physician.
So the legislative process is very slow, and it's often influenced more by anecdote and emotion than it is by evidence and logic. And so as an emergency physician, and I'm sure you can relate to this in your leadership role, we'd like to think that logic and evidence and peer-reviewed data is what will influence policymaking. And it does, but you can't do that alone. And so the challenge, I think, for physicians and emergency physicians in the legislative process, in the political process, is that it's not just the science of medicine you need to bring the art of medicine, how we relate to people, how we build trust with people. That is a critical part of the political process. And so for me, the transition was kind of merging both of those things in this role as a state legislator.
Physicians being involved, that's big. We as ACEP support federally physicians, not just emergency physicians, but physicians of all types, seeking office, both right and left, because, the flu doesn't care who you voted for. How do you, as a physician here, message the importance of physicians willing to take that jump that you took?
What I tell physicians who are thinking about being involved in the political process is that it's in not only our self-interest, but our patients' and our community's self-interest to be politically active. Everything we do in the emergency department is influenced by decisions that are being made in Frankfurt, in Harrisburg, in Washington, D.C., and capitals around the country. We need physicians to be more willing to tell their stories, more willing to engage in the political process, and to understand that how we deliver care to patients is directly influenced, for better or for worse, by decisions that are being there. The challenge is that the two things that matter in politics, not policy, but politics, are time and money. Mm-hmm. And physicians generally are challenged when it comes to both in the political process. We're busy professionals and don't have the time that other stakeholders do in the political process. And frankly, we don't contribute into the political process at the level that we can and should, given our level of remuneration compared to other stakeholders in the healthcare system. And so that's the challenge, to try and bridge that.
It's interesting because there's a coal lawyer that I was on a trip with, and he says it's easier for him to squeeze $1 out of a rock than it is out of a doctor. Mm-hmm. And then he followed that up by saying, if you tell me right now I need to raise $150,000 for trial lawyers, I can do it at the drop of a hat. Mm-hmm. And that's been an ongoing issue. I think a lot of that's just because we spend most of our years broke, mm-hmm. Or in significant debt, mm-hmm. that when you finally have something, you're trying to pay off things and then catch up and then hopefully retire one day. I wanted to talk to you about the vacuum that sometimes exists. Like, if you're the only physician legislator in Pennsylvania, there's one of one. What is the concern, and what happens when there is that knowledge vacuum that if Arvind wasn't in the Pennsylvania House, that exists there? Because the bills are still going to come. And this is part of that motivation as to why physicians need to be involved, not only from an advocacy standpoint, but somebody running for it.
It's really, really important. I mean, I was on the advocacy side. I was active with ACEP. I was president of the Pennsylvania chapter. I remember traveling to Harrisburg and being the only person in a room who had actually cared for patients, saw patients, still seeing patients. Everybody else was a lawyer, a lobbyist, or staff member. And what happens in every state capital and in D.C. is that vacuums get filled, and it gets filled by the people who are willing to show up, who are willing to tell their stories, who are willing to influence the process. And even now, as a state legislator and the only physician there, I have to be careful because there are healthcare issues which clearly I'm not expert on. Mm-hmm. And so I take it seriously that my colleagues come to me and ask, what is your opinion about this issue? To go back, almost like I'm a medical student, to look up and learn about issues from experts so that I can, influence and inform my colleagues in the most responsible way possible. And so I definitely agree that we need more emergency physicians and more physicians inside the electoral process, in addition to being more active in advocacy, because otherwise that vacuum will be filled by bad or ill-informed perspectives.
Now, you mentioned when we were doing our prep call for the session we're doing tomorrow, that you showed up day one, and not just the rash person or whatever, but the fact that you showed up day one and were the healthcare expert. Mm-hmm. I don't know of any other profession, and maybe you can tell me, that immediately is the go-to knowledge source within a legislative process. Do you know of any other things or areas where somebody comes in and they're automatically the go-to for that versus a physician, and how does that help impact and drive possible healthcare-related legislation that you're all of a sudden the expert?
So my colleagues come from a variety of backgrounds, and I legislate on every issue under the sun. There are definitely colleagues of mine I turn to on banking issues or accounting issues or legal issues, like from the lawyer's perspective. But I think what's unique about healthcare is that it is so widespread in our society. It is very personal, that everybody has some type of interaction with the healthcare system, and that it is rare to have health professionals in the legislative process. I'm the only physician, but I'm one of like 5 out of 253 legislators in Pennsylvania who have any type of health professional background. So I think that combination means that healthcare is usually front and center, and people do reach out to me and my other fellow health professional colleagues to get their perspectives.
Now, you ran and were elected as a Democrat in Pennsylvania, but your expertise and your ability to guide legislation is not one-sided. It's blue and red. Talk about the ability to, as I mentioned earlier, illnesses don't care how you voted or what you believe in or whatever. Sick is sick. How does your approach in being a physician translate into kind of bringing together the parties, understanding that healthcare is everybody?
Well, most of the issues we face, even in healthcare, are not partisan. They're not red or blue issues. And I have taken the approach that I take as an emergency physician. When I see a patient, I don't ask about their ideological background. I pragmatically try to approach how to care for them. That's true in the political process, too. I mean, if you ask my colleagues, Republican or Democrat, they would almost certainly say, Arvind is someone we can have a conversation with. He's going to present it straight to us. He's going to say, these are the challenges that you might have ideologically, but this is why I think this is important. And so on healthcare issues, the issues that I've championed largely, whether it's medical debt relief or expanding insurance access or regulating artificial intelligence in healthcare, I'm the lead sponsor on those bills, but those are bills in partnership with Republican and Democratic colleagues. And so I think the background as an emergency physician, where we don't have time for pontificating and ideology, we're pragmatically trying to address the challenge for the patient, really translates well into that political process to build trust on both sides of the aisle.
All right, let's talk about that. Emergency physician. How does being an emergency physician representative help you, and where do you think it may drag a little bit, may make some things a little bit difficult?
So I think where it helps is that everybody has some experience with emergency departments. We are not a hyper subspecialized field of medicine. And so whether the issue is insurance coverage or opioids or medical debt or whatever the issue is, I have a pragmatic and real world experience with those issues. And so I think that helps a great deal. The other thing that helps being an emergency physician is our, super talent, so to speak, our superpower is building a trusting relationship with someone very quickly. That's the essence of politics as well, is that even though it's not fast moving, there's a lot of things going on. We're used to multitasking. We're used to understanding interrelationships. That helps a great deal as an emergency physician. The challenge is the political process is very slow, and I don't know any emergency physician that likes slow, except when they're done seeing patients and they don't want to say the Q word. But we all have a degree of attention deficit disorder, and we want to be able to take action quickly. The political process doesn't work like that. So that's the pluses and minuses that go along with it.
Have you tried federal? Because then it slows down even more.
Yeah.
It's like a 10-year plan. Everything you have is a 10-year plan. All right, so let's pull back the curtain just a little bit. The relationships. Of course, right now in the news cycle, everything is very polarized, much more on the federal side than on the state side. But even being from Kentucky, there's still a lot of tension between Republican supermajority within our House and Senate and a Democrat governor. Talk to me a little bit about the public perception of relationships, like the fact that just it's every day the red and blue is like the gangs of New York ready to fight over a rabbit or whatever. But you tell me a little bit about the relationships and the realities of politicians working together on a daily basis, and how is it different than what we see that's publicly portrayed?
I think the biggest advantage that we have as state legislators is that we're not on TV every day. We're not preening for the cameras. And so, yes, we have our public moments. Yes, we point out our differences. But again, because most of the issues are not red and blue, it's pretty easy for me to find partners on the other side of the aisle. The other thing that helps is I am in a very purple district. I'm not in an overwhelmingly red or blue district. So my constituents rightly expect me to build relationships across the aisle because they're not overwhelmingly Democrat or Republican. And I sit in a state house where there are 102 Democrats and 101 Republicans. We have a Republican state Senate and a Democratic governor. We have to find ways to build bridges, otherwise nothing gets done. And so that's, I think that's actually a helpful thing that I'm from a district that will reward bipartisanship, and my unique background allows me to find areas that I can work across the aisle pretty readily.
And that is an important consideration, is how do you balance, personal beliefs, feelings, views of Pennsylvania, the country, the world, while representing that purple district, putting those priorities of a diverse voter population into account when you go to your capital.
So as an elected official, I think it's my responsibility to say to my constituents, and frankly, I also represent the physician community in Pennsylvania too, is to not compromise on my values. The values that I put forward to my constituency are the ones that I should bring every day into elected office. But on the outcomes, like if you can get a half a loaf or if you can move the needle a significant bit in a way that you might not be expecting, then it helps to be able to compromise on the outcomes even as you stay hold of your values. And so that's the balance that I try to bring. And so the issues I focused on, I think that we're able to find that common ground even if the outcomes are not 100% of what I wanted. But Ronald Reagan said, if I get 75% of what I want, that's a win. And so that is something that I take to heart every day.
Let's do last little question. What's a day in the life, the average session, you're there, when you're at the Capitol, full-in session, give us a day in the life of Arvind.
So it's a whirlwind. So, our legislative session weeks are Monday, Tuesday, Wednesday. Usually I'll show up early on Monday from Pittsburgh to Harrisburg, about a 3-hour drive. I'll have committee meetings in the morning. I'll have meetings with different stakeholder groups who want to come and meet with me about different issues. There will be press events. There will be discussions about legislation. Then we will convene the House. We will have, ceremonial aspects of convening the House. Then we'll go into caucus to discuss the bills that are happening that day. Then we'll go back to the floor and vote. And then in the evening, there may be fundraisers, there may be lobbyist dinners, things so that you build relationships on issues. What I think doesn't get understood is that the vast majority of work happens well before we come to Harrisburg. When we come to Harrisburg, the die is cast. Everything is scheduled. Everybody knows where everybody's going to be on their votes. The real art and science of legislating, if there is one, is all the work you do ahead of time to talk with your colleagues, to talk with leadership, to talk with lobbyists, to talk with your constituents, to negotiate a product that then when it comes up to vote in Harrisburg, there's no surprises there. So it's always busy in Harrisburg, but what I tell my constituents is, meet with me back in my office in my district, because that's when I'm going to be able to be hyper-focused on you and your issue. And frankly, most of my constituents aren't following the ins and outs of legislation. They're following whether my staff is responsive to their needs with state government. Am I out in the world at events? Am I taking care of the issues that they think are important? And am I, staying true to the values that I promised them that I would? That all happens before I get to Harrisburg.
All right, talking with Dr. Arvind Venkat, State Representative, 30th Legislative District in the House of Representatives for Pennsylvania. So if you're looking for that office, go check out the 30th Legislative District. How can folks get in touch with you if they want to reach out and kind of roll from there?
Sure. So my official website is repvenkat.com, and anybody can send me a message there or email me. And my campaign website is venkatforpa.com, and there's a way to message me and support me as well. So both of those ways are easy ways to reach me.
And we're going to continue the conversation because this is actually a two-part discussion that we're having here at LAC. And the next part is going to be with Dr. Timothy Reeder, who's also in the North Carolina House of Representatives. And so two views there. And so I appreciate your time coming in, sneaking in here a little bit early to get this knocked out. And then for the podcast itself, we're going to combine those two interviews. So let's turn it over now to our interview with Dr. Timothy Reeder. Having our conversation with Dr. Tim Reeder, practicing emergency physician, elected to represent the 9th District. It was interesting earlier when we actually had our conference that it mentioned District 9. And I thought, this sounds more like Hunger Games than it does anything else. But North Carolina House of Representatives since 2022. Earned his medical degree from the Ohio State University. It was Ohio State at that point. They've added the since then, before moving to North Carolina in 1998, working full-time at East Carolina University in the Brody School of Medicine, master's degree of public health from the University of North Carolina, Chapel Hill. So thanks again for joining us. This is a continuation of our conversation because we had Dr. Arvind Venkat representing Pennsylvania. We have two emergency physicians here. So give us a little background on your path from emergency medicine to saying, I want to jump in to the rat race of politics in North Carolina.
Well, thanks very much for having me. And it was a jumping in. So I had done a lot of policy and advocacy work for the North Carolina Medical Society. I had been on their board. I was the president of the state society in 2019 and had thought for a millisecond, would I ever run for office? And I said, there's no way. Life goes on. I was doing my academic career teaching, and I literally got a phone call one night from a previous representative, and I didn't answer right away because I thought he wanted money. And so he texted me and said, I really need to talk to you. Answered the phone, called him up, and he said, I want to talk about politics. And I thought, oh, you got me. You want some money. And he said, no, I want you to run for office. And then he kept saying, we want you. And I was like, who are these we people that I had never heard of? And started the conversation that night. And then the next day, I had a couple phone calls because I really didn't anticipate or know what I was getting myself into. Talked to the CEO of the Medical Society, and I called him up that morning, and he said, it's great. I hear you're running for office. And I said, I got a phone call 12 hours ago. I'm not running. And he and I talked about what this would mean for physicians, what this would mean for our profession. And he said, you have a week to decide. Your name is at the top of the list, and if you don't tell them yes this week, they will go to the next name on the list. And so thankfully, whatever fate worked out, I didn't have a lot of shifts that week. And so I made tons of phone calls and threw my name in the hat. And so that's how I got into this. I had never been in local office, had not really even thought about doing this. And it was a baptism by fire because I just sort of jumped in with 2 feet and started the process, which I came to understand in a pretty quick way how different this was than anything I'd done before.
Well, let's talk about that because most of us here in Washington, over 400 physicians are here, and we probably a small percentage of doctors overall actually participate in the advocacy of medicine. But then you take that step further. Talk about that difference that you go from being a physician advocate to the legislature to now you're on that other side receiving that information.
Yeah, I was probably, because I was so ignorant, I didn't know what I was getting into. And intellectually, you know that there is a whole industry for campaigns. And so, after I said yes, then they said, okay, who's going to be your treasurer? I don't know. Who's going to be on your campaign? I don't know. So thankfully, I had some people to help me through that process. Fast forward, I go through a ridiculously complicated and expensive, both primary and general election. So the general election, it was the second most expensive House race that year, and I won by 354 votes out of 30,000. So just barely over 1%, so we didn't have to have a recount. So now I'm elected, and now I'm the dog who's caught the car. I don't know even how all this works. So show up, and again, like many things we do in medicine, you find mentors, people who have been there to say, help me understand the process. Thankfully, we had one other physician in the General Assembly when I got there. She was a psychiatrist, child psychiatrist, who had been there for a couple terms, and so she took me under her wing like we do in medicine, and she showed me the ropes and helped me out in that first term.
You mentioned in the talk earlier that two makes a caucus. So
It-
having another physician, you were actually able to caucus.
It was, and she was there all by herself. And so when I got up there, I can't imagine what it would have been like to have just one physician with all of the things that were going on. And she joined the General Assembly during COVID. So she got oriented virtually, all of those things that had happened over history. It was all during COVID, so it was very different for her. And when she decided to retire, thankfully another OBGYN put his name in the hat and he ran successfully. And so we still have two in the 170 people who make up the North Carolina General Assembly.
All right, so Arvind told us his first curbside consult story of showing up to his first day. You also got to play doctor your very first day as well. Tell the story of showing up to get sworn in, thinking it's going to be a day of family, raising your right hand, all that good stuff, and how it changed.
Yeah, and it was funny, even before we got up, before we had the swearing in, I was talking to the Speaker of the House, and he said, make sure you bring your prescription pad. And I said, well, Speaker, I'm not sure that I'm allowed to do that up here. You know, these aren't my patients. He said, well, what happens at the General Assembly stays at the General Assembly. And I said, okay. And I said, Speaker, I don't own a prescription pad. We do it all on the computer. And he said, well, you better find one. So that was even before I got up there. I said, okay, what am I getting in for? But right, we were getting sworn in the first day, and it was in the evening, and the chamber was full, and it was hot, and the Supreme Court Justice was going through a speech, and we're all standing up to swear the oath, and they go through all 120 seats. And one of the members who I'd never met passed out on the floor. And so I jump over, 20 desks to run up to the front of the chamber, and there he is sweating and pale, and he looks terrible, and he is not young. And so I thought we were going to have to code him on the floor. And normally we have a little bit of space, but because of all the guests, we had chair upon chair upon chair. So we literally threw him in his chair, wheeled him out to the back of the clerk's office, called 911, got the AED, and he turned out just fine. But afterwards, I learned more about his medical history, and he was 70-plus years, smoked 2 packs of cigarettes a day for probably 70 years, and he wouldn't go to the hospital. And so it was a good lesson. So after that, I said, I need to learn more about our members.
It actually reminded me of when you told the story, it reminded me of one of the races we went to, and a person had a cardiac arrest in the stands.
Yeah.
They go resuscitate, AED, shock, all this stuff, and then the person wanted to refuse going to the hospital and wanted to stay for the race. We're like, that's not how this works.
Yeah. Well, and that's what, and what was not great about this experience, but there was other nurses in the chamber who were close by who didn't move. And so I got up there. So the entirety of the leadership for the whole session, and still goes on, these nurses didn't move, but Dr. Reeder got there before they did. And so in their mind, it just sort of reinforced what we do as a specialty. But he refused to go to the hospital. So I left him in the office, and then we go back in the chamber. We're going to do the swearing in. Well, he wheels in a wheelchair with the paramedics behind him, and he wants to get sworn in. So I thought, okay, he's going to do this and then go to the hospital. No, he drove himself home, and the highway patrol followed him in his car until his family could meet him halfway. And he's still in the chamber, still doing well. And we've never really spoken about that event afterwards.
So you mentioned, because that's a great segue, because you mentioned you being the physician, showing up there. They call you doc.
Yep.
From day one, your doc, which is amazing, is kind of like the tradition of everything culture. It's once you're doc, you're doc.
Yeah.
I mean, the entire time. But talk about walking in as an MD and the immediate kind of street cred you get by walking in and being that education with regard to healthcare policy.
It's something that physicians in general have in society. Even though our standing, the perception in the public is lowered now after COVID in the public health, most people still believe that physicians are thoughtful and smart and have some degree of credibility. And so walking in on those healthcare issues, there was a natural deference sometimes for us. And at my first term, we were debating hotly Medicaid expansion. Mm-hmm. And so that was, in our caucus and the Republicans, there were some people who were really set against it. They didn't think that was a proper role of government. And because I was armed with stories, and so the story I told all the time is we had a woman who I took care of in the emergency department. She didn't have any money. She didn't have insurance. She couldn't afford Synthroid, right? Dirt cheap medicine. We admitted her to the hospital several times for a myxedema coma because she couldn't afford our medicine. And so the story I told to other members is we spent thousands, $100,000 on this woman in the hospital for lack of a cheap medicine. This is what Medicaid expansion will do. And so that, I think, helped resonate with some of the members. And that's one of the things that when we talk about advocacy is telling stories is so powerful for legislators. It helps get the hook in them so they can then understand the deeper policy issue.
Unfortunately, so much of it is that understanding of spending a little bit of money to save a lot of money. You mentioned $100,000 or whatever it is for a hospital stay for $15 worth of medication that would have gotten her through 6 months, in trying to tell those stories from that standpoint. But the challenge being, as physicians, we have a very scientific approach to the world. You show me the evidence, show me the research, and that's what drives my decision making. That was the challenge with COVID, is so many people were frustrated and upset that we would change our view, we would change our mind, we would change our recommendations. Well, that's what evidence does. Politics isn't that way. Talk about when you show up, kind of transitioning that physician mindset of evidence-based decision making, because you already told me that the evidence there, make the decision, move on. And that's not how politics works. That transition or that evolution of being able to have that mindset of a physician and then translating that into politics.
I want to think, and maybe I'm delusional, that the science still helps guide my decision making. And so one of the things that we all learn is for figuring out which ideas, which things are going to work on which legislators. Sometimes you can come with the scientific, here's the data, this is why this is important, here's the economics of it, and you can have that. Some of it you have to rely on those personal anecdotes. Sometimes you just have to say, listen, I just need your help on this one, and there's nothing in it for you, and you're going to take some hits, but can you do me a solid? And so some of it is strategy. As you are thinking about bills from both sides, how and what argument is going to work for this member, or who is close to this member that I can do. And there are sometimes, there's some horse trading, right? I know you need help on this bill. If I speak on it, will you either be quiet because you're going to speak against it, or can you speak for it? And so there is some of that sausage making that goes on. And I think that was one thing that I had to learn a little bit. I thought I was going to be able to show up and here's all the arguments and my rhetoric and was going to work, and it doesn't all the time. And so you just have to think differently and be much more strategic than I had anticipated when I got up there.
That's a lot of the messages we have here. You mentioned the individual ways of messaging to individual members, and we do that here in Washington. Like, we're going to this office, this is what we're going to focus on. This is what they're interested in. We're going to go to this office. This is actually what we're going to focus on. Even though it's the same topic, we're going to move the spotlight just a little bit.
Yeah, I think that some people think that we're monolithic and they say, well, it's a Democrat issue, a Republican issue. And in healthcare, it's not always that clear cut about where are the politics. For sure, there's a couple issues in healthcare clearly along partisan lines, but many of them, there's a nuance. And sometimes it might be a good policy, but how far do you go, or how much money do you spend to get whatever the topic is? And the other thing that I've come to understand is that being incremental is perfectly fine. We would love to pass this great bill that will solve all of boarding. That's probably not realistic for government to work that quickly. We talk when we're thinking about policy. If we need to have a legislative fix for something, that is a failure often of the people who should be solving the problems. Legislation is very crude, it's very blunt, and especially in healthcare, it can't possibly think about all the nuances of what we do. So we try to legislate on a particular bill, some insurance coverage. Well, there's always exceptions to that. And so it's always better, I think, if we can figure out a way to do it absent legislation, because the process is slow and you're never sure what the outcome. I mean, we might start off with a bill that looks great and we've got a bunch of supporters, but as that goes through the process, things get added on or taken away, such that sometimes I've had a situation where I didn't even want to vote for my own bill because so much other stuff got put on it, and it's still got my name, it's my bill, but we call it a Christmas tree. All of these other things have gotten hung on, and you say, this is a bad bill, and so I'm going to vote for my own bill, or vote against my own bill because of what happened during the process.
You actually mentioned that during the session this morning, and I was like, you don't want to have a bill that's too popular and too favored, because then you're right, the Christmas tree, everything gets hung on it until it finally just becomes too heavy and falls over. You've mentioned, Arvind mentioned the idea that no matter if a physician is present or not, healthcare legislation happens. Kind of hit on the fact that the importance of having a physician in the room. I think you made the Hamilton reference earlier today. Having a physician in the room to kind of guide some of the good policy and kind of pushing back some of the bad.
Yeah, there's a quote from Calvin Coolidge that's attributed to him, and he said, "I'd rather kill 1,000 bad bills than let a good one go through." And that's what in our General Assembly we had 1,017 bills filed this year, and we're going to pass 100 of them. Some of them are well-intentioned on both sides, right, Democrat or Republican, but they just don't understand the real issue that they're trying to solve. And it could look very innocuous, but it can be incredibly detrimental. So some of it, because I'm a health chair, we can just choose not to hear any of those bills. So the one that I always go to is we've had scope bills for the last 10, 15 years in North Carolina. And the health committee has just refused to hear the bills. So it's filed every year. The nurses come up every Tuesday to the General Assembly. And last year, or last term, if the vote ever came to the floor, it would pass, and we'd have expanded scope. But because we had health chairs and a speaker who wasn't in favor, it just never got heard. And so we can just stop bills just through that action. Now, the downside is we have good bills that go to the Senate, and they don't hear them. You know, we had a number of good bills. One of them was regulating the CBD. So in North Carolina, you can buy it. There's no age restrictions. So we had a great bill to regulate it, prevent it under 21, and it got sent to the Senate, passed the House 120 to 0, essentially, and went to the Senate, got sent to the Rules Committee, never to come out. And so it happens on both ways.
And you mentioned that earlier, that it really isn't as much the party debate as much as the chamber debates.
Yeah.
We see that in Kentucky, where one side Senate may pass something, it'll make it to the House, never get heard, vice versa, the same way around. So it's not as much about red and blue as it is House versus Senate and trying to get those relationships built together.
Yeah, for sure. And some of that is just the advocacy. In North Carolina, the insurance companies have spent most of their time in advocacy efforts in the Senate. And so we have, we passed some really good prior authorization in the House, but the Senate has just dominated by the insurance companies. So they took, I'm biased, my really good bill and put a bill that wasn't so good related to prior authorization, but it was written by the insurance companies. And then they sent it back, and now again, it has my name on the bill because that's where it started. And people's like, why are you doing this stuff? I'm like, that's language that was put in by the Senate, it's not me. And so we're still working on that, and we're still negotiating that bill.
All right, so a little bit of a lighter-hearted question to kind of wrap up today.
This is a piece of cake. This is all easy.
This. So the best part and the worst part of being in the legislature.
The best part really is the ability to influence a wider network, a wider policy issue. I love taking care of patients. I'm going to be doing that Thursday. You have tremendous impact on that patient's family, right? That is so important to me. Still love it. When I teach, you have a big influence that goes on. I mean, I feel like there's things that I've taught residents and medical students that they're teaching to the next generation. So that's really cool. In the General Assembly, when we pass laws, the violence bill, that will be there because of the work that I did. And so I'm really proud of that kind of work. So that is really fun. I am an introvert, like off the scale. So this may sound weird, but meeting new people who I otherwise wouldn't have met, that is also very, very good. Now, I'm exhausted with it after I go knock doors and do these things, but it's really fun. The hard part is raising money. I'm getting better at that. I went to Catholic schools, so I learned how to sell things. The frustrating thing sometimes is the legislative process and what sometimes you can't get done because of some of those politics. And so that's frustrating. There's no opposition, but because some bill, idea, policy, it's just caught up in the politics that have nothing to do with me or the bill. It's just there's other stuff going around. And we saw that. We were negotiating with the Senate on a number of health bills, and we had these omnibus. And so, okay, we're going to put 3 Senate bills together. We'll put 2 House bills. Well, can we put this one in there? Well, we've already given you 2, and that seems like an equal trade. I said, but what about this one? There's no opposition. This is great policy. Yeah, we can't do that because that would be giving you guys too much. That's frustrating.
All right, talking with Dr. Tim Reeder with the 9th District of the North Carolina House of Representatives. How can folks get in touch with you, reach out if they have questions, maybe want to jump into it, or also support what you're doing in North Carolina?
Yep. So Dr. Tim Reeder, DrTimReeder.com. So, your listeners, they're smart if they can't figure out how to get a hold of me. But so that's my campaign. You can go to the North Carolina General Assembly, ncleg.gov. We have a link. I'd love to, if any of the listeners are thinking about it, about running for office, love to talk to them about that. If they just want to know how to be better advocates, love to talk to them about that. I've given an advocacy talk to medical students across North Carolina, across the country, from medical students all the way up to events like this. I really want to get physicians engaged in the political process. So I can come do a talk, I can do it on Zoom, I can do it in 10 minutes, I can do it in 2 hours, anything in between. So happy to be there.
I appreciate the time, and thanks for coming in, for being part of our conference here. Our conversation with Dr. Reeder and Dr. Venkat. We've got the video version here with Dr. Reeder. If you want the combination, we'll have that on the audio version of the podcast, and appreciate everything and joining us, and great information that you've had. We've now had several conversations, great information. Interestingly, both you and Arvind had a story about not answering the phone because you thought somebody was going to be asking for money.
Yes.
He actually was taking somebody to the hospital because they needed care, and the person there said, "Well, I didn't answer because I assumed you're asking for money."
Yeah. It is an unnecessary. It's necessary. It's an unfortunate part of the process because campaigns are expensive, and every one of those yard signs that people see, those are $4 each, and so it adds up quickly.
Well, and since you're on a Q2-year cycle, it's always.
Yeah.
As for me, you can contact me, rstanton@acep.org, rstanton@acep.org. I ask everybody to subscribe to the podcast, and whatever your favorite player is, give us a 5-star rating, give us some feedback, help boost us up in the list. Until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Ding. Quiet place, all
Yeah.
alone. Da, da, da.